Good afternoon, dear colleagues. I'd like to thank you for the opportunity to present my commentary on the impact of COVID passports in Lithuania, published in Journal of Infection. I'm Rimas R.Jankūnas. I'm a pharmacologist, so my field of interest includes the effects of medicinal products on the body. The subject of my scientific research is adverse reactions to medicinal products. Earlier, I worked as Deputy Director at State Medicines Control Agency of Lithuania, responsible for marketing authorization, supervision of clinical trials, and pharmacovigilance. Also, I was a member of various committees at European Commission and European Council. What is the background of our paper? Lithuanian scientists who were involved in establishing governmental COVID policy published a paper speculating that COVID passports prevented hundreds of deaths in Lithuania. They also think that COVID passports could be an effective measure for controlling future pandemics. They also insist that Lithuania relatively successfully managed first COVID wave in spring 2020. Me and my colleagues cannot agree on that. Any medicinal intervention should be based on scientific evidence. So let's look on that. Before any intervention, we should consider what evidence is available. We should look at the evidence-based medicine. So what was the scientific evidence for COVID passports? Surprisingly, the basis was a false claim that vaccination prevents the transmission of COVID. However, the endpoints of clinical trials on COVID vaccines neither included effect on transmission nor effect on mortality. Despite conflicting data on COVID transmission, vaccinated people got COVID passports automatically. So, what scientific evidence did we have? They supposed initially that vaccination will prevent transmission of COVID and will lead to pandemics of unvaccinated individuals. The claim was false, and the pandemic of unvaccinated individuals did not happen. Endpoints of randomized clinical trials of COVID vaccines neither included the effect on COVID transmission nor on mortality. Nevertheless, we got as we got. So, are COVID passports based on science? No, it is much simpler. In Lithuania, the concept of COVID passports was prepared by the Ministry of Economy and Innovations. First time, they were introduced on 24th May of 2021, so after viral season. Are those who invented it aware of innate immunity? Are they aware of mucosal immunity, which plays a key role in respiratory infections? Are they aware of immunoglobulin A? Look at COVID travel passports in EU. They were shamed to science, basing on vaccination status or COVID test, but stupidly neglecting natural immunity, both innate and acquired, and scanning of QR code instead of thinking about science. So, I go back to the paper published by the governmental scientists. After reading it, I acknowledged that they have no studies behind, only mathematical modeling. Consequently, the governmental scientists presented a narrow view. Then, what is the position of COVID passports in evidence-based medicine? Let's have a look at the pyramid of this medicine. Remember that for marketing authorization, level 1 evidence is required. In case of COVID vaccines, we have level 1 evidence from randomized controlled clinical studies only for prevention of symptomatic disease and prevention of severe disease. Regarding transmission, the evidence is at lowest level and includes contradictory expert opinions, mathematical modeling, and some ideas or speculations. I acknowledged that a study of the effects of vaccines on transmission would be highly complicated. So let's consider the randomized controlled clinical trials, the mortality in neighboring countries, the natural immunity, spread of infection, and public health dimension. Let's also evaluate the management of first COVID wave in spring 2020 in Lithuania. So this is number of cases during COVID. Can you see first outbreak? I will help you. It's here. Does it mean that the management was successful? The governmental experts insist that yes, based on low prevalence of COVID antibodies and on utilization of hospital sectors. But we are convinced that this means that they did not understand what happened yet. Let's have a look on the SIR model of infection spread. So S means susceptible. Initially, all subjects are susceptible. Then they get infected and transit from susceptible to infected. Afterwards, they recover and became resistant. If we compare with Sweden, Sweden did not apply a lockdown in spring 2020, and therefore quite a lot of people transited from susceptible to resistant. Lithuania applied a strict Chinese-type lockdown, so both prevalence of COVID antibodies and utilization of hospital sector were low. So this means that they flattened the curve dramatically. And I'm sure that so-called successful management of the first COVID outbreak in spring 2020 just postponed the morbidity and mortality to the tragical winter of 2020-2021. So we consider that this management was unscientific with terrible consequences. Low prevalence indicates just an initial stage of a pandemic. Due to strict lockdown in spring, Lithuania postponed the morbidity and mortality. Successful management of any pandemic implies minimal excess morbidity and mortality with as low as possible long-term consequences to public health, which are, of course, unavoidable. Making mistakes is normal, especially with unknown infection. However, the incapability to learn from mistakes is an issue of concern in science. So, randomized clinical trials. Let's have a look on endpoints. Primary, prevention of symptomatic disease. Secondary, prevention of severe disease. It is about COVID vaccines. Duration of blinded phase, less than half a year. Finally, never effects on transmission nor mortality was investigated as endpoints. And by the way, criteria of severe disease included saturation of oxygen below 93% in the room at sea level. So this means that some patients were not able to know that they have severe disease without a special device. Let me provide a simplified explanation how the efficacy was calculated in randomized controlled clinical trials. Let's say that we have 1,000 trial subjects in the vaccine group and 1,000 subjects in placebo group. And let's say that we have one case of disease in vaccine group and 10 cases in placebo group. This means that so-called relative risk reduction is 90%. We protected 9 persons of 10, which would otherwise get infected. Meanwhile, absolute risk reduction is 0.9 because we protected 9% of 1,000, which we had as participants. It's also to be noted that guideline on the summary of product characteristics requires both relative risk reduction and absolute reduction to be mentioned. However, this requirement was neglected during COVID crisis. By the way, these percentages, despite simplified, they reflect more or less real percentages which were obtained during studies of mRNA vaccines. For adenovirus vector vaccines, relative risk reduction was smaller, meanwhile absolute risk reduction was higher. Then, a highly important point is mortality, and unfortunately, it did not serve as endpoint of randomized controlled clinical trials of COVID vaccines. These trials did not have adequate power to investigate mortality. Duration of life phase was too short. However, luckily, brilliant Danish scientists made an ad hoc analysis of all randomized clinical studies involving more than 1,000 subjects. They did not find statistically significant differences in mortality in vaccine groups versus placebo. However, still, they noted some differences. Just numbers were different. So, for mRNA vaccines, the number of deaths was higher in vaccine groups in comparison with placebo groups. Especially high is the increase in cardiovascular mortality, but still it did not reach a level of statistical significance. Surprisingly, the number of deaths in adenovirus vector vaccine groups was lower in comparison with placebo groups. The cardiovascular mortality in vaccinated was also lower. Still, the differences did not reach the level of statistical significance. However, if you have a look on cardiovascular mortality, it is quite close to the level of statistical significance. Then, excess mortality in other countries. First, let's have a look on neighboring countries. In red, we have neighboring countries of Lithuania, which had COVID passports in winter 2021-2022, and in green, countries which didn't have COVID passports at that time. And here we have average excess mortality per 1 million of population. Definitely, excess mortality in countries without COVID passports was more than twice lower in comparison with countries with COVID passports. And this is data source, our world in data. We just looked at the excess deaths at the introduction of these passports, then at their revocation, and made calculations. Next, other database. The Economist reports that Lithuania has the highest excess mortality in the world during period of COVID. Nevertheless, the governmental scientists applaud that they prevented deaths with their COVID passports, face masks, lockdowns, and vaccines. And this is a new publication, fresh publication of excess deaths in the Western world. It comes from British medical journal Public Health. Scientists from Netherlands calculated the total number of excess deaths excess deaths in 47 countries of the Western world from the beginning of 2020 till the end of 2022. They took all countries where the data is available and calculated that in 2020, with lockdowns, the excess mortality exceeded 1 million. In 2021, it even increased with lockdowns, vaccines, and COVID passports. In 2022, then most of containment measures were lifted, COVID vaccines continued, and the excess mortality decreased but persisted. We had a nice previous presentation on the immunity. So this was completely forgotten during times of COVID. We have an innate immunity, which is natural, and adaptive immunity, which may be active or passive. Active immunity may be natural after infection or artificial after vaccination. During COVID crisis, natural immunity was erroneously neglected, and possibly it was done due to commercial reasons. Now, in the absence of data on transmission from clinical trials, let's have a look what did Health Security Agency of United Kingdom reported. So they calculated unadjusted rates of infection among persons vaccinated and unvaccinated per 100,000 of people. And they found that the number of COVID cases was several months after vaccination lower in vaccinated population, but later it turned to be higher, and not simply higher. It was 3 to 5 times higher in all age groups starting from 18 years. This is some kind of cross-sectional case control study. Quite simple to conduct, but still raising important hypotheses for further investigations. Then advocating COVID passports, governmental experts say that the effect of COVID passports was delayed. How, where could be delayed if governmental experts, if people without COVID passports were never able to work, nor study, nor visit shopping malls, nor entertain from the first day of the application. Also, governmental scientists say that 1,000 infections daily is the psychological threshold for changing behavior. But they do not explain how COVID passports can be involved in changing this behavior. As you know, they were directed to prohibitions, not to behavior. So in the absence of explanations, their model is based on non-existing data. Let's have a look on Delta and Omicron waves in Lithuania. So COVID passports were introduced on September 13th and revoked on 5 February 2022. Look, after application of COVID passports, still number of COVID cases continued to increase during 7 weeks. Then they started to decrease and then started to increase once again with Omicron wave. By the way, the peak of Omicron wave coincides with the day of revocation of COVID passports. Of course, I don't say that Omicron wave stopped because of revocation of COVID passports. On the contrary to governmental scientists who say that Delta wave was stopped because of COVID passports. Next, comparison with Poland. Poland is neighboring country for Lithuania. This is the same period, the same pattern of wave, just they have COVID passports. So the question, what is the explanation to the stop of Delta wave in Poland? There is no idea from government. But the response is obvious. It is a herd immunity due to natural immunity after infection. Now, Sweden and Norway, even more funny, they also didn't have COVID passports. Smaller Delta wave in Norway, it's in green. By the way, Norway had lockdown in spring 2020, but no lockdown in winter 2020-21. And Delta wave doesn't occur at all in Sweden. So, what can be the reason? Maybe the reason for devastating Alpha and Delta waves were previous lockdowns which prevented the development of at least the partial herd immunity. Sweden, no lockdowns, no Delta wave. Next, the epidemiological situation in Lithuania after the introduction and revocation of COVID passports. The number of COVID patients in hospital at revocation was 1.5 times higher than at their introduction. The number of daily COVID deaths at revocation was almost twice higher than at introduction. The number of confirmed cases at revocation was 13 times higher than an introduction. So this means that the epidemiological situation dramatically deteriorated during the application of COVID passports and started to improve after the revocation. So obviously, COVID passports did not change the pattern of COVID waves. They only served as basis of discrimination, damaging human rights and economy. Public health dimension. A key principle of public health is to work so that individuals can make good choices and care for their health. Exponential spread is a mechanical process. Meanwhile, people in society observe, communicate, learn, and take precautions without any order, unlike animal herds. COVID passports do not consider this, dehumanizing people to the point that we are only pawns in a puzzle. And also, I should mention ethical consideration. One of governmental experts which advocated COVID passports in this paper did not disclose the critical direct competing interest. So he was member of advisory board under the government of Lithuania. In conclusions, during the period of COVID passports, Lithuania had highest excess mortality in the Baltic region. The epidemiological situation with COVID passports deteriorated. The claim that COVID passports prevented hundreds of deaths has no scientific evidence, and there is no scientific data to prove that COVID passports could be an effective measure for controlling future pandemics. I thank you for your attention, and I will be happy to respond to any questions.